Good evening, everyone. Thanks so much for coming. This is a great turnout for our first speaker night of the year. So my name's Arabella Rawpa. I'd like to welcome you as the Chair of Global Hands to our first speaker night, the first of many, I hope. So we're in for what promises to be a very interesting and thought-provoking night with our two speakers tonight. Before we begin, I'd just like to acknowledge and pay respect to the traditional custodians of the land on which we meet, the Gadigal people of the Eora Nation. It is upon their ancestral lands that the University of Notre Dame Sydney campus is built. As we share our own knowledge, teaching, learning and research practices within this Notre Dame Sydney campus, may we also pay respect to the knowledge embedded forever within the Aboriginal custodianship of country. So I'd now like to introduce and invite up Emily Moroney, who is our maternal and child health rep in second year. Emily's done an amazing job with all the organising of tonight, so huge thanks to Emily.
Hi guys, thank you so much for coming. I'm super grateful and really excited for what's going to be, I hope, a really great speaker night for our first Global Hands speaker night of the year. So without any further ado, I'm going to introduce our first speaker. So our first speaker for the night is Laura Latina. So just a quick little bit about Laura. Laura is an experienced midwife. She currently works on as a women's health advisor for Médecins Sans Frontières. She's previously worked across the globe in countries such as Afghanistan, Kenya, South Sudan and Malawi. She's coordinated and managed large maternity units, as well as undertaking a role as training midwives. More recently, she worked in Italy and England and has overall assisted in more than 500 live births. She recognises the importance of education and is a qualified advanced life support in obstetrics instructor, trainer and mentor in midwives. Laura believes in looking after women right through from the beginning of pregnancy to the postpartum stages and aims to empower women to make informed decisions and choices to make positive health experiences. So we're really looking forward to hearing from Laura tonight regarding her wealth of experience. Please introduce Laura.
Hi everyone. So I don't need to introduce myself. You know already. Just a little bit, just to add to what Emily said, I work here as advisor. So here in Sydney, we have a small medical unit. We have actually the maternal and child health unit. And we belong to Médecins Sans Frontières or Doctors Without Borders. And our headquarters is in Paris, but actually we have this medical unit here, so you are lucky to have us, me as representative tonight. So to start, I just want to explain you a little bit about MSF. When I say MSF is Médecins Sans Frontières, we call MSF, we always say MSF. So MSF was born in 1971 and as an NGO, an organization, non-profit or non-governmental organization. And everything started because of the Biafra in Nigeria. And two doctors and two journalists went to build emergency hospital or emergency department where they could take care of children and adults. And the journalists then reported, the journalists and the doctors witnessed and reported to the world what was happening. And then actually MSF was born in this way. And then the organization expanded. And now we are in many places in the world, and I will show you where exactly. And we do take care of, we always, I would say, the first line for emergency, natural catastrophe, epidemics, refugees, but also we have some long-term projects, like maternal health project, pediatric project, TB, tuberculosis, HIV. And so we have these two different sides. And I'm going to go into that later a little bit. Here where we work, so I would say the majority of the projects where MSF works is in Africa. We also growing in Asia and Middle East, a little bit in South America, and in Europe. We have project in Italy, in France, in Greece for the immigration. And who works with us? So we are a medical organization, for sure, but it's not only doctors, nurses, midwife. We have really a variety of professionals working with us. We can't work without a logistic team, so Watson, our engineers, architects that build our hospitals and make them functioning. We can't work without a human resource leader and pharmacists, lab technicians, so it's really, really broad team. But I also want to say that, of course, us as international staff, we work and we go there, but the majority of the work is done by the local staff. So when we go there, we actually mentor, supervise, we give our support to the local staff, to the staff that is already there. And usually it's about 30,000 national staff that MSF works with, and about 3,000 international staff. So you can see that the majority of work is done in the field by the local staff. And we are there just to aid, support them. Yes, and these are some pictures just to introduce you a little bit on MSF words. So this is our typical work. So we go in conflict zone. This is Iraq. We set up tents, especially in zone where the infrastructures have been destroyed by the wars and conflict. So we go there in less than few days. The logistic team build up, set up the tents, and the medical team is ready to work. So this is really, the work is done in few days. And this is a triage, and you see international staff usually are the one with the white jacket, and the national staff are the rest with the one with purple, so we work together with them. And what we do is in the tent, and we also have operating theater in the tent. You will see this is a tent built in really nothing in one day, where we also try to respect all the rules about aseptic rules and etc. So like a proper OT. So, but tonight I'm gonna focus a little bit more on maternal and newborn health because it's my specialty, but also because women represent 50% of the population and 25% of them are in reproductive age, so from 15 years to 45 years. So just a little bit, I want to give you this statistic data just to understand that the context where we work is really different from Australia, Europe, US. It's really, really different, and we work really in extreme, with extreme cases. When I was a student, I've never seen, I studied some of the situation that I dealt with in my experience, but really it's a completely different world. And I will explain you why. So in a year, we have 211 million pregnancies, 87 million unplanned pregnancies, and 25 million of unsafe abortions, and 303,000 maternal deaths. This is a source from WHO in 2015. It means that around 830 women die every day. So it might not mean anything to you, but what I want to say that in context where MSF work, we see women dying every day, and I'll explain you why. And we don't see it here as often in Australia, in Europe, in US, in what we call developed country or high-income countries. For example, if we take a country like Sierra Leone or a country in Africa, we have a 239 per 100,000 live births versus 12 per 100,000 live births in developed country, or even less. Sometimes in UK it was 8 a few years ago. So just to see that really we do see a completely different situation from what we can see in our home, in our countries. And 99% of all maternal deaths occur in developing settings, so where MSF works. In Africa, majority in Africa. Then we have Asia, Middle East, South America. So why do women die? So the causes, what we call are direct obstetric complications. So hemorrhage, bleeding during pregnancy, during delivery, after deliveries. We have complications due to abortion, so women might die for unsafe abortion. We have complications during labor. The labor can be obstructed or prolonged. We have infections, and we have what we call preeclampsia and eclampsia, which belong to hypertensive disorders. And we have also ruptured uterus. So why this happened? I'm going to explain a little bit later why this happened, but I just want to tell you that this does not occur in our countries. This occurs just in countries where we work, in Africa, in developing countries. And in fact, in our country, in Australia and Europe, women die because of different causes, what we call indirect causes. These are direct causes because it's the pregnancy itself that might create this complication, and women die because of this complication. But in our countries, women die for completely different causes. It can be this, but the majority of them would die for mental health, cardiovascular disease, and not for this, because these causes we can prevent this. Here, we have access to all hospitals, we have drugs, we have qualified staff. When these occur, so women have the risk to die during beginning of pregnancy. This is because of the unsafe abortion. And then it drops a little bit, and the risk of dying is biggest during delivery. So what we do to improve this in context where MSF work is we try our best to do every activities to implement. We implement in the project. The majority of the activities that we do is really to make sure that the women have access to the hospital, so that that risk will decrease. But where we work, unfortunately, is really difficult. Women don't have access to the facility, and in some area majority of area where we work, we don't have qualified staff. And I'll tell you more about it later. What about newborns? And for newborns, I mean the first 28 days of baby life. So we saw mothers, but even also for the babies, we have 1 million of newborn die the first day of the life, and the other million die the next 6 days. So we have actually really huge number of baby dying, and again is most of them, 99% of them is in developing countries again. Here in our country is completely different. Again, it's the same thing because we have access, we have qualified staff, and we have resources. But why newborn, why babies die? So we have 3 main causes for asphyxia. So this means that when the baby is born, because of something happened during labor, during birth, or even before, and we don't know. The baby is born with a respiratory condition or distress, and this might put at risk the baby. And if you are not able to do anything, if you don't have the resources, if you are not trained to do a good neonatal resuscitation, the baby might not survive. And then we have the infections, different type of infection. It can be the baby already born with an infection because it took from the mother during pregnancy or during labor, during birth, or it can be afterwards, the first week, the first day, or the following weeks. And, but the first cause is actually preterm birth, so baby born before the expected date, so before they are 9 months of pregnancy. And this also, being born before can really be a distress for the baby because it's really difficult for the baby to survive. So what we do in our maternities, in our projects, is that we usually have a really basic, it's what we call helping baby breathe. It's really, really basic tool that we implement to help the staff to start ventilation. So with the ambu bag, because for the baby it's really important, so we call golden minutes. Because in the first minutes, you need to have a good chance that the baby survives in case of asphyxia or in case of respiratory distress, to take your ambu bag and to ventilate the baby. So this is really basic things that we do. And we try to, all the staff in maternity and newborn unit to know very well. And also what we put in place is to treat infections and to take care of the baby that they are small weight, so preterm baby. With kangaroo mother care is what we do, that is skin to skin. That has a lot of benefits for the baby. So what you see is actually really basic steps. We don't have incubators, we don't have really high standard resources or tools. We really start from the basic because this is the main activities, the most important activities that actually can save life, and this tool really can save, can prevent asphyxia, can save baby. And one of the reasons why we implement these basic steps is that in some of the projects, for example, in South Sudan, we don't have qualified staff. In South Sudan, I think few years ago, they have, since few years, medical university, so nursing, midwifery, but before, you couldn't find any qualified staff in the country. So we needed to work with people that have a small experience with medicine or medical background, or people that had 9 months trainings as community health workers. So really, we can't implement higher standard technical resources because it's not sustainable for the country, for the staff. So we start from the basic. And also, of course, one activity that improves neonatal outcomes is antenatal care. So this is what also we provide in our projects. Or another option is that we work with the Ministry of Health in the countries. So we are not standalone projects, but I would say half of the project that we have, we work in collaboration with staff and collaboration with the government, because one of our objectives, what we want to do is to really, maybe in 5 years, in few years, in 3 years, hand over the projects, and we want that the country continue working with their resources. So we don't want to implement or introduce high or many activities. We really want to support them and then them working alone. So going back to why, and this is similar for newborn, why do women not get the care they need? So why do we have all this denied access to care? So why we said that women die for causes that are different from here. So I would explain with this theory that is called 3 delays theory. And you can look if you are curious more from WHO. So we have 3 delays, which is in seeking care, in reaching care, and receiving care. So what does it mean? So the first one is, I will give you a really practical example. A woman is in labor in a village, and she needs to make the decision to take her stuff and go into a facility. Because she wants to give birth to a facility, health facility, because she feels safe there. But usually the husband is the one who makes the decision for her. He's not around. He went to work somewhere. So she can't get the final decision, and so she's stuck home. This is what really happened. So nobody allows her to go to the hospital, so she can't go. And she's stuck home, and she needs to give birth home with the women out in the village. This is one situation. The second one could be that she's in labor. She has complication. It might be that, for example, she bleeds, but she thinks it's normal to bleed during labor. And she doesn't go to the hospital because she thinks everyone say around her that it's fine. So if we take this example, and I would say the woman that is bleeding, and she keeps bleeding, and then at the end, after one day that she keeps bleeding, she realized that probably is a good time to go to the hospital. But when she decided she would go to the hospital, actually she realized that she doesn't have any transports, and the village is really far from the hospital. So she calls many people. She doesn't have a phone, but she tried to reach many people or someone that can bring her. So, and this again caused delay, because to reach someone that has a bicycle or a motorbike, it would take at least 10 hours. So once she actually finds the motorbike to go to the hospital, she's already sick. She's collapsing. And they try to bring her to the hospital. Once she arrived to the hospital, actually the midwives and the doctors, they are there. They think she's fine, so they don't give her anything to treat the bleeding. And then after 6 hours, she dies. So this is really what it happens in the countries where we work, and this is seen really every day. It might be one, blockage, one barrier. It might be that she takes the decision after 12 hours, but then she reached the hospital very quickly. It might be that they don't have any transport. So she's stuck home. Or they might be that finally she reaches the hospital, but the staff are not qualified, or they think that she's fine. So all this delay can really have a really negative impact on maternal health access, on maternal health. And that's why we have all those deaths. And this doesn't happen here, because we have transport, and we have we know during antenatal care or during pregnancy, we talk with the women, we tell her all the danger signs, we have access, we have qualified staff. So completely different situation. And last two slides are about global health issues that we see in countries where we work. The first one is sexual violence. In 2017, we treated about 20,000 victims, but I would say the majority of victims that they reach the hospital are women. but we know that it's not just a women problem, it's also men and children. About 20% of the patients that we treat are children. And one of the biggest problems that we encounter is that this issue is underreported. Women, children, men don't come to us easily to get the care they need. And often they don't know that we provide this kind of care. And so they stay in the community. So we try really to engage with the community. We do focus group as well to raise this issue. Another issue that really we encounter in developing countries, unsafe abortion. When I talk about unsafe abortion is an abortion, a termination of pregnancy that the women induced by themselves to terminate the pregnancy, but done in an unsafe way. So it can be through herbs, through instruments, it can be through someone that is not qualified and give them all the instrument to terminate the pregnancy. So this is really, it's becoming an issue that we see often in our projects. Women coming with septic abortion and dying. And we, maybe many years ago, we didn't think that this was a huge issue. And even myself, when I studied or when, before living with MSF, I never seen a woman dying for unsafe abortion, but I've seen many when working with MSF. So what we do is actually we try our best to treat women, so all the emergency cases. We talk with the women about contraceptions, because you see in the previous slides we have a huge number of unwanted pregnancy, and this is the one of the issues that they terminate their pregnancy because of unwanted pregnancies. So this is, and for this reason, because we have seen the burden of it, we've seen so many women dying for this. For International Women's Day, we created a page and we talk about the issue. We have witness from the field, and also we talk about all the burden that we see. I don't know if we have time, but I will continue with my presentation. If we have time, I can show you one of the video. You can go and look. So I want to talk about two of my experiences. So before, a few years ago, I was a full-time midwife for MSF, and I've been to different countries like South Sudan, Malawi, Afghanistan, Kenya, and I was there for 6 to 9 months. One of my tasks was to be supervisor, be the manager of the maternity and supporting the national staff. And then I took this role as an advisor, and it's a little bit different because I give support remotely through email calls, but also I go and visit the projects. And when I go and visit, I work with the national staff, with the international staff. And one of my area of expertise is quality of care. So I make sure that the way how they work is safe and is a high standard for what we want to provide to the women. And I give you two different contexts. One is Bangladesh, and the other one is Nigeria. So, and two different problematics as well, and contexts. So at Bangladesh, we have a refugee, the Rohingya refugee camp, and I will show you some pictures. Oh, this I will show you later, but I want to show you actually the camp when these pictures are taken by myself in like 360 degree, because when you are at the top of the hill, you think it never ends. It's 1 million people. So they estimate that all the Rohingya population have escaped from Myanmar. So, and they're all there in Bangladesh. So it's really, it's really immense, huge. And this is where they live, in kind of shelters. And inside the camp and outside the camp, there are many facilities. Many NGOs are present, and they do different type of care, pediatric, adults, maternity. So MSF built a hospital for small maternity, adult wards, and pediatric. And this is, I went there when it was just opening. So this is the delivery room and the first baby born in the delivery room. And this was a simulation. So the midwife was playing the role of the patient, and I was facilitating a simulation about bleeding. So, and we were having fun, talking about how is our care about what can we do when a patient bleeds. So, and we were discussing also. We were doing a real simulation and discussing. So sorry, I'm going backwards to just some of the MSF data. So what we did in 2018. So we did almost 5,000 antenatal consultation, 505 postnatal consultation. So you will see the difference. We have a huge number of women coming for antenatal care, but then for postnatal care, so after the delivery, they don't come because in their culture, they don't want to go out with the newborn baby. So they prefer to stay home. So because of this, we actually, we are changing our strategy. So we are looking into supporting the women at home, and for us to go with our outreach team to their home to give assistance after birth. So helping with breastfeeding or helping with anything that she needs. So this is me with Lucy. She's another midwife, and we were going through the camp because we have a small hospital, but we also have some clinics around where the women can access for antenatal care, postnatal care. We also have family planning service, which we did 1,558. And PAC means post-abortion care. So it means all the women that came in with unsafe abortion or bleeding because of abortion. And then we opened the maternity very late in the year. So really the end of the year, we did 61, we assisted to 61 births. But the majority of the activities are really outpatient, so providing the care in the clinics. And now going home. Okay, this was Bangladesh, and my last examples or experience was in northern Nigeria. So we do have 2 projects in Nigeria, which is it's called Jahun, which I'm gonna talk about, and it's close to here, around here, and the other one is Port Accord, is here, and these projects about sexual violence. So we only have vertical sexual violence projects. We give care, we provide care to victims. So the one in Jahun is a maternal hospital, and again, this is a collaboration with the Ministry of Health. We do support the maternity, this maternity was built in 2008, 10 years ago, so 2008. And these are actually pictures at the beginning when the when the project opened. And the women give birth to twins, the expats, or international staff, and the national staff, the local midwife. So this again was, you see, is a tent. So we were doing surgery in a tent again. And then it was temporary because we wanted to understand what the needs were at that time. Then the project expanded and we had lots of women coming. And I'll show you some data as well. This was at the beginning in the neonatal unit. Really basic, you see a few beds, the oxygen, that's all. And this was the tent. So the hospital was built initially, yes, it was a maternity, but it was built to take care of fistula. And I don't know if you, fistula, obstetric fistula is again another big issue, a global health issue that we don't see here. When I studied, I didn't, nobody told me or taught me about that. And the first time that actually saw a case of fistula was my first mission, because a fistula creates when a woman has a prolonged obstructed labor, and is often an, I would say in bracket, African problems, because for this delay that we saw, the woman might stay sometimes even up to 5 days at home in labor. And so what happens is that the baby is in the pelvis, and staying 5 days for the babies is not possible in labor. So usually the baby dies and the tissue so because the baby is inside the birth canal, it creates, the tissue is so damaged because the baby wants to get out, but it can, so it's so damaged and it goes necrotic, so it dies. And it creates this, it's not a medical term, hole, but it really creates like a hole between the vagina, the urethra, or the uterus. So the women lose urine without control. They can lose stool without control. So, and it needs really a complex surgery that now only few surgeons in the world can treat this. And we have one of the surgeons in MSF that goes regularly to treat these patients. There are also other hospitals, like there is a famous hospital in Ethiopia that does this, but there are really few surgeons in the world because this disease or pathology exists only in the countries where they have delay and they don't have access to surgery, to early surgery. So this hospital is still there, and these are the women treated from fistula. So they actually close the fistula, and they need to do lots of rehabilitation afterwards. So there is really an ongoing program. So the women are admitted, and then after months they do surgery, and then they stay in the hospital to do rehabilitation. And the program still exists. And in fact, I put like 10 years challenge. This is what it looks. I've been there in November, so they're really recent. They expanded because I will show you many women come to this hospital. The ward sometimes is we have 2 patients, 3 patients per bed. And so why, I want to explain you why MSF is in Jahun, so in northern Nigeria. Because as I said, as I mentioned, there is delays in access to care. So the women come very late in a stage during labor that is too advanced, and sometimes we might lose the mother, we might lose the baby. But in that area of Nigeria, we still have lots of home births done by traditional midwives, which are not trained. We have use of herbs, traditional medicine. We have issues with the husbands, so they don't give consent to the women. And we have issues with transport, so the villages are really far from the health facilities. It's an area where we have a high maternal mortality and even newborn mortality. And actually what we see there, we don't see in other parts of the world, because we have high rates of complication. So we do have around more than 7,000 deliveries per year, but 60% of those deliveries, those births, are complicated. And we don't see that rates in other projects in MSF. So it's really high. We do have lots of hypertensive disorders, so women with high blood pressure, convulsing during labor, during birth. We don't see these in other parts of Africa as well. Maybe Sierra Leone is the other one. But they arrive very late. So, and for this reason, we see lots of complexity afterwards. So we have lots of cardiomyopathy for that, because the women are not treated during antenatal periods, or they don't come. We also have a huge rate of anemia. So women coming with hemoglobin very, like 1.1, 2.1, which is like, I don't know how they are alive. So very low iron in the blood. And so the reason why we are there is that it's not the right word, but it's kind of interesting in terms of women's health, because we can really have an impact providing basic care, giving drugs, training our staff, providing activities in the community. And very quickly, this is what we do in the hospital. So we have 96 beds. We have a post-delivery. We have neonatal unit. We have, of course, labor room. We do see almost 20,000 pregnant women attending in our triage, and as I said, 7,500 roughly are deliveries that we assist with 60% of complication, and we have the highest rate of maternal deaths, which is 127, which is really high. The reason why we do have that is because, again, women come very late in a stage where sometimes we do everything, but we can't save them. So because of that, because they arrive very late, the hospital itself is not really, doesn't solve our problem. And we actually supporting Beemans, which is, Beemans stands for Basic Emergency Obstetric and Newborn Care. So it's a health facility which provides all the maternal and newborn activities, but it's basic. So we do mainly normal deliveries, antenatal care, and then we refer to what we call CMONC, which is a complex, a comprehensive health facility with surgery, with blood transfusion. So this is how we work in, usually in MSF context. So the hospital itself is not really, doesn't solve our problems. What we need to go out, and what we did in this case is that we went out and we're supporting 3 facilities with supervision, with trainings, we train staff, but also we do health promotion. So we go in all villages and we tell women to come to the facilities, and we provide antenatal care, postnatal care, and also busy units. In 2018, they had almost 20,000 antenatal care, with almost 2,000 deliveries. Yeah, and they're very, very close to the hospital, so that if we have emergency, we can reach very easily. So just to conclude, yeah, of course, it's a beautiful experience, and you can really understand that the context is different, and we don't really, we see cases, we witness cases that personally I've never seen, and so it's always, you need always to be updated, to study, and of course to adapt to the context, to adapt to the culture, And you have big frustration because sometimes this is a picture of South Sudan, and they're not midwives, but we train them. And it's sometimes so frustrated because we speak different languages, we have different approach or cultures, and you can learn really a lot, but sometimes it's really frustrated. It's a continuous fight, but we do have lots of fun, and actually, for me, they change me as human, but also as professional. So that's all. I hope you enjoyed, and thank you.
Thank you so much, Laura. That was pretty amazing for us to be able to get that perspective. And yeah, we'll ask some questions later on. We'll just hear from Dr. Roach now. So just quickly, we've got Dr. Roach. Dr. Roach is the president of RANZCOG and the former chair of the Gidget Foundation. And he also is involved in the teaching of Sydney Uni students and then us in third year and as well at Notre Dame. And so we're very honoured, and I'll introduce Dr. Roach.
Thanks, Emily. So I'm the light entertainment. You've heard the serious stuff and you've heard what incredible work that you're doing, Laura. And I'm very humbled when I listen to what you're doing and recognise the conditions under which you do it as well. Is that for us, I had an interesting conversation with someone the other day who's working on the issue of postpartum hemorrhage. And when you do your own G-term, you realise that one of the reasons why you bleed after you have a baby is because the uterus doesn't contract down. And if that happens in Australia, one of the techniques, there are many, but one of the techniques is to put a balloon device inside the uterus. And we have one which is all packaged up and it's called a Bakri balloon. And then you put fluid into the balloon and it tamponades the uterus. And they cost $500. And so you get a Bakri balloon and then you go, oh, sorry, I dropped that on the floor. And so then could somebody please get me another Bakri balloon? And I was talking to this chap and he works with the Bill and Melinda Gates Foundation. And it's always very interesting when someone doesn't refer to the Bill and Melinda Gates Foundation, but they talk about, I was having a chat with Bill and Melinda. And they said, and he said, you know, we recognise that in low resource countries, we need to develop some kind of thing. And so they worked out that if you used a condom and you had a syringe and you had fluid and some string, you could achieve a similar effect. But he said, but the problem is that when we developed all this, we realised that the price point was just a bit too high. And so we've had to go back to try to reduce it because the original price point was $12.50. But we've managed to bring it down to $2.50 and we think that's about what, price will be acceptable to save a woman's life. And so I think that the work that you're doing is extraordinary, and I think that it's almost impossible for us to relate to that context. It's just not something that happens. I come from the North Shore of Sydney and I didn't realise that there was a world outside of the North Shore of Sydney. And in fact, it was quite an extraordinary experience just crossing the bridge. And so to imagine going to Africa is just beyond anything that I could possibly cope with. But I think that it's so important that we're given that perspective and that we constantly remind ourselves. Another thought that went through my mind as well when you talked about frustrations is that overwhelming sense when we do talk about global health of how can we possibly make a difference to those numbers? How can you stand on that hill and look at 1 million people and think that you're going to do something? And I'm reminded of a story in which there's a beach and there's been a huge storm and washed up on the beach are a whole lot of starfish. And an old man who's tired and cynical is walking along and he comes across a little boy. And the little boy is picking up the starfish and trying to throw them back in the water to save them. And the old man, who's tired and cynical, says, little boy, this is ridiculous. There's 1 million of them. You're never going to make a difference. And the little boy bends down and he picks up a starfish and he throws it back in the water And he says, well, it made a difference to that one. And I think that that's a really important thing to remind ourselves, and for you to reflect on it in those moments of frustration when it's so overwhelming, when you can't save all of those women, when you can't make a difference to all of them, that for each woman who's in front of you and their family and the community that they're connected to, you make a difference to them. So I acknowledge you, and I'm grateful to you for the work that you do. So I was given a sort of very broad brief. Why don't you just come along and talk? Okay, I'll just come along and talk. And so I put together, well, what is my day? And it's one of the interesting things in being an obstetrician and gynaecologist, I think in being any health professional, but I'll talk specifically about my specialty, is that there is an entire life in one day. And my journey to being here, I think you don't suddenly arrive here. And the message that I want to give you today is that you're going to grow into these positions. So I too would like to acknowledge the indigenous people. And when I do that, I have to do that now a lot in a sort of ceremonial way. We begin all our meetings that way. The college has a reconciliation action plan. I hear it said at just about every conference that I go to or event that I go to. And I want to try to do more than that, because I realise that my relationship with indigenous people is an intellectual one. Is that I'm one of those latte-sipping, Chardonnay-drinking, socialist, lefty, self-righteous type people who says, isn't it terrible what happened to the indigenous people and we should all be ashamed? And then I thought, no, I didn't want it here. I wanted to feel it here. And one of our fellows, we only have 2 Indigenous fellows in Australia, and she gave a talk. And in the talk was a video, and she said, what was really important was for us to try to understand the concept of advantage. And so the video shows a whole group of people all lined up, ready to do a running race. And the person says, at the end of this running race is $100, and whoever makes it there gets $100. And so we think, well, yeah, the fastest person is entitled to that $100. And he says, but before you start, would those of you who have grown up in the same house please take 10 steps forward? Would those of you whose parents are still together, could you take 10 steps forward? Would those of you who have not experienced domestic violence or substance abuse, or who have a tertiary education, or have all the things that maybe some of us might take for granted, take another 10 steps forward? And you know where that's going, and what they do eventually is turn around and look backwards, and the 2 Aboriginal people are still standing on the line. And then you say, okay, let's begin the race. And of course I go and I grab that $100 and I think, that's because I worked hard and I studied hard and I was the fittest person, which is highly unlikely, as you'd say, and therefore I was entitled to take that $100. And so it's worthwhile every now and then reminding yourself of the advantage that got us to our starting position, and therefore our sense of entitlement might be tempered a little bit. The other reason that I put up a slide of family when I talk to medical students is that I say, welcome to the family. So all of you can remember that you made that decision that you were going to do medicine. And you agonised over and you worried about it and you thought, should I really do this? And I better not tell anyone. And then eventually you think, okay, well, I'll tell mum and dad. And mum and dad say, oh, it's so exciting and we're so wonderful. And then they call everyone around and you're sitting there at dinner and your aunt's sitting next to you and your aunt says, I've got this pain here in my side. And you realise that suddenly there's a whole different perspective. There is a whole different perspective on you because you have decided to study medicine, that you are going to be a health professional. And the only difference between you and me is that I'm old. And I am an older member of the family. But from the day you decided to join medical school, we became connected, and we belong to a part of society which the rest of society holds in very, very high esteem. We are valued. All health professionals are valued. Doctors get this special position, and And with it comes responsibility, with it comes opportunity. But what the reason for talking to you about it is so that we all remain feeling connected to one another. And the only difference between you and me is that I've been on the planet for longer. As I'm going to tell you, I'm definitely not smarter. I'm definitely not more skilled. I've just done it for longer. And so I say to you, welcome to the family, and that I am glad that I am connected to you. And that's the reason why I accepted your invitation. So they talked me up, this legend. And so I thought, well, I have to live up to that. And so hence I wear a cape most of the time. Living up to that reputation, though, isn't always fun. And when I talk about the journey to leadership, in fact, being a leader is actually often a very, very, very lonely position, because the expectations that people have of you are enormous. And you can't deliver on them. And you can't keep everybody happy all of the time. And particularly if you take positions on things, then you're going to make a lot of people unhappy. Last year, there was the referendum or plebiscite on same-sex marriage. And so we started getting emails at the college, and we had to make a decision as to whether we would issue a statement or not. And there are 7 of us on the board. 5 of us felt quite strongly that we should issue a statement in support of same-sex marriage. And 2 people felt very strongly that this was a political issue, this had nothing to do with the college, and it wasn't something that we should do. So I thought about it, and I thought about it, and I thought about it, and I thought, okay, how can I get them across the line? And I put it to them that this was actually a health issue. Yes, I agree it's a justice issue and an equality issue and all of those other things, but if I was to get this group of people across the line, that we would talk about it in terms of health, and that as health professionals, we had a responsibility to care for the entire community. Now, we know that 70% of people agreed with that and 30% of people didn't. And similarly, in our college, it was exactly the same. And therefore, I would get, after we issued that statement, hate mail. I would get horrible texts. One that I actually, you can, if you press the wrong button, then all of your texts are gone. Well, this one I deliberately pressed because I just couldn't bring myself to know that that was there. I would get bailed up in the car park. You have destroyed the college. This will be the end of the college. Well, as it turns out, that isn't the case. And so leadership and wearing your cape can be great fun. It can be an ego rush. It can be a buzz, an opportunity to meet lots of people and do lots of amazing things. But it can also take its toll. And I also talk about leadership in the context of medicine as well. So my medical career did not start auspiciously. My friends, when we were sitting together sort of 10 years after we'd all finished medicine, and we were sitting and having dinner, and I was thinking I was being very humorous, and I said, oh, you all thought that I was least likely to succeed, didn't you? And they all just kept on eating their dinner and decided it probably wasn't best to go there. And in those days, unlike you, we didn't have the sort of student ID and you log on and you get your results. Our results were all put up by name on a board. And so we all used to troop down there to see whether we'd passed or failed. And my friends told me that what they used to do is they didn't bother to look for their own name because they're pretty confident that they'd passed, but they all used to wonder whether this time I'd passed or whether I'd failed. So I was a little upset by that, but anyway, that was, and I think, I failed 50% of the exams that I did, but I did them again. And so I used to spend... And so I spent, and this is not, sadly, I wish that I was telling you this for entertainment, but unfortunately it was true. And I just couldn't get it together because I was just partying. And there we were, out getting wasted until 4 o'clock in the morning, and then you think, oh, well, I should probably, no, never mind, just sleep in, and then you'd fail. And so I somehow or other, I was saying to my children, you should all study harder. This is ridiculous. I can't believe that you think that a pass mark is okay. And I went out to get out my university transcript and I saw conceded pass. And I thought, okay, well, we'll put that away and we probably won't discuss that again. And so I got to the end of my university, and in those days you were appointed to the hospital for your internship based on where you were in the year. So I was sent to the least popular hospital in New South Wales. I had the advantage, unlike you, of going to a real university called Sydney University, but okay, How to lose an audience in one. And but I was sent to the least popular hospital in New South Wales, which all that time ago was Royal Prince Alfred Hospital. Nobody wanted to go there. And my first shift was at midnight at Campbelltown. And I turned up in Campbelltown, and there's a resident downstairs looking after Kaz, and I'm looking after the ward. And I get a phone call saying, this bloke's got chest pain. So I go up there and I'm thinking, I thought I had chest pain. And then I'm thinking, I remember, you stick an angine under the tongue. So, sister, put an angine under the tongue. This is a midwife will be rolling her eyes now, thinking this is like having a junior obstetrician who has absolutely no idea what they're doing. And it didn't work. And so I thought, oh, well, if the one doesn't work, surely another one will. And then the nurse who was there said to me, maybe you could give a bit of morphine. Sister, I'd like some morphine. And so after I overdosed him on morphine and angine, his pain went away. Anyway, he spent the night in intensive care and I think recovered. But I also discovered that in those days we didn't have the internet, so you couldn't Google stuff, and we used to see a patient in casualty and then we'd go to our books in another room and we'd try to work out what was going on. And a woman came in the middle of the night and she had a severe headache. And I took a full history and I did a full examination and I worked out that she just had intercourse. And I said, did you have an orgasm? And she said, yes. And in my books, I found the diagnosis of benign orgasmic headache. Legend. So I went in and I explained to her that she had a benign orgasmic headache. I gave her pain relief. She got better. This is it. This is like going to be my subspecialty. So a few weeks later, a woman comes in. By chance, when I take her history of her severe headache, she's had intercourse and she's had an orgasm. There you go. They wheel me in, the person with the best education in this area, the greatest knowledge, and I explain to her that she has a benign orgasmic headache. So the next morning, when the helicopter flew her out with her subarachnoid hemorrhage, I realised that actually you can't always be sure that because you've seen one. And I went back to being a dunce. I had by that time decided that my passion was going to be obstetrics and gynaecology. And I'll talk a little bit later about why that was the case. And I think my understanding of that has evolved over time. But probably a lot of it had to do with, and it'll be your experience as well, of the people who you came into contact with during your student or junior doctor years. In those days, and it's just a fact, and it's something that we obviously are reflecting on now, in those days all the obstetricians were men and they were just a bunch of good blokes who I liked and I related to and I got on well with and who I drank quite a bit with as well. And you're seeing a common theme here. And so I thought, I want to be part of that club, I want to hang out with those people. And so I was at Royal Prince Alfred Hospital and then we did our O&G term. And it was my internship when I came back to Prince Alfred in particular and when I did my residency where I really got it together. I was confident, I was able to communicate, I understood my medicine, not those first few stories, but it got better. And I really felt like I was able to function well and I was the most likely to succeed now. I was going to be the one who'd be appointed as a registrar at Royal Prince Alfred Hospital. You had to sit a Part 1 exam and there were 4 of us and there were 2 jobs and then, true to form, I failed the exam. And so 2 people who passed were given the jobs at Prince Alfred and 2 of us were found jobs elsewhere. And I was found a job at Royal North Shore Hospital where I'd been a medical student. And I went back there very unhappily. Didn't want to be back at Royal North Shore. I'd been very happy at Prince Alfred. But I went back and I was a first-year registrar and I passed my Part 1, I got my act together, I became the youngest person to pass my Part 2, the youngest person to be a senior registrar, the youngest person to qualify as an obstetrician and gynaecologist because finally I had found my passion and found what interested me and what I loved. And that's the key, really, is that if you do enjoy what you do, if you get up in the morning, then it's okay. And you get a buzz out of it, and you need to find what aspect of it is that you enjoy. And if you are lucky enough to discover that, and we need to remind ourselves, and I'll talk about that a little later, is that that's not always the case. We are in a privileged position. Then it's not a question of that sort of work-life balance concept, because work becomes part of your life and your life can be your work. It's just a question of hopefully that you're getting a taste of all the things that life has to offer. And so there I was, legend. And when I finished my training in Hong Kong, I flew back into Sydney, I started my own private practice, and I had so many patients. You talk about obstetricians sort of on average delivering about 20 patients a month. So I was delivering about 40 or 50 patients a month. I had one particular month when everyone else was away and I was covering everyone, and I delivered 90 babies in 1 month. And I was young and I was able to do it, and you didn't have any sleep, but you were just on a high because you were getting this extraordinary feedback. And, one of the great joys about being a midwife or an obstetrician is the appreciation that you have, because it's such a significant moment in someone's life. And I got to share that. But eventually, it was more than I could deal with. And so, at some point in time, it all came crashing down. And I was exhausted, I was fed up, I wasn't enjoying it anymore. And effectively that was going to be the end of my career. And that was 5 years in, but many thousands of babies and this amazing reputation, and I didn't want to do it anymore. And we were at a party and I was listening to this couple talking about how they were about to take 3 months off and travel around the world. And I remember I could feel my heart thumping and thinking, we have to get home so I can talk to my wife, Kathy, about this. And we got home and I said, what do you think? Maybe we could do that. We could take the kids out of school for a term and we could do it. And she said yes, and we took the children out of school, and I took 4 months off, which nobody had ever done before. Consultants don't do that sort of thing. You might go and do study leave or something like that. But this was that I would stop for 4 months. I would have a locum who would look after the practice, and we would travel around the world. And it wasn't something to make a movie about, but it was this extraordinary experience of just stopping and pausing and being with my family and being with myself and having the opportunity just to breathe again. And when that was over, I came back to work, but I came back not because I was really looking forward to going back to work. I actually would have been quite happy being on holidays for the rest of my life. But I came back with an understanding that work was part of my life, and that was the deal, and that I wasn't in a position to walk away from that, and that I had a role to play, I had a job to do, but that I could do it maybe a little bit better. And so I started taking weekends off. I started prioritising a little bit more, booking holidays, still working ridiculously hard. I tried to, I thought, how do you limit your numbers? Because they're just pouring in through the door. And so you say, can I sort of interview someone and say, I quite like you, I'll look after you, but you can't do that. And so then I thought, okay, well, what I'll do is I'll say, if I've met you before, as in if I've looked after you for some other reason, then I'll continue to look after you. So you're looking after your multips, or you're looking after someone who you might have seen for some gynaecological issue in the past. And then I'd have someone sitting in front of me, and I'd say, so do you have any period problems? They'd say no. Do you need a pap smear? And they'd say no. Is there anything in particular you like to discuss? And they'd say, no, but I'm on your books now and I'll see you in a couple of years when I get pregnant. And that's how crazy private obstetrics could be. And you can see that's why I have such a big ego, because when you're getting that kind of feedback, it's very hard to remain humble at all. But I wasn't the only one who'd gone through all of that. And I know this is a sort of continual thing that you get told. You get told so much that doctors get depressed and anxious that you end up being depressed and anxious. Or you feel like you're the abnormal one if you're feeling happy. So we need to acknowledge this, though. We need to acknowledge this because we need to realise that we are not different. It's going to happen to you. It's going to happen to you where you see yourself as a doctor as a different species to the patients that you're looking after. But in fact, that's not true. And even if our rates are the same or less or more, they're there. And so we are susceptible to mental illness, we're susceptible to physical illness, we abuse substances, our marriages fall apart. We have all the things that our patients have. And we need to realise that it's not them and us, but that we're exactly the same. I sit there talking to a woman about her weight, realising that every morning when I wake up, I go on a diet. Unfortunately, by the time I get home, that diet's gone. And so who am I to talk? I now actually speak very openly about it, and I chat about my battle with trying to lose weight or become fit. And I saw someone who I hadn't seen for 12 months, and she said, "Are you still walking up the stairs?" And, you know, and it engaged her, because I wasn't saying you need to go and do your exercise. I was acknowledging the difficulty in doing it. Who's ever finished a course of antibiotics? Not me. So that we say, and so we have this sort of perception, and as if you don't swallow your antibiotics with a glass of beer. I mean, that's what. So the thing is that to think that in some way a patient should behave in a way that we're never going to is unreasonable. To think that we will not experience anxiety or depression or suicidal ideation is unreasonable. That we don't have bullying or sexual harassment at medical school or in our colleges is wrong. We need to acknowledge that the things that apply to the rest of society apply to us as well. And then the other thing that was happening, and I realised as well, was that I was driving home at 5 o'clock in the morning after having been up all week and up all night that night, and I'm driving home at 5, literally so I can have a shower and a shave and turn around and go back to work to be back at work at 7 o'clock, and I'm feeling pretty miserable. And I'm thinking, I'm a doctor and I work so hard and what I do is so important and valuable, and it's really rough, and I've got it the worst of everybody. And then I'm driving by and I see the milk bar man lifting up the shutters, and I see the newsagent putting out the papers, and there's a taxi rank, and those guys have probably been sitting there for most of the night hoping that someone will come and have a fare. And the garbage men are driving their trucks, and I'm thinking of on New Year's Eve how all the police have their leave cancelled and they have to be on duty. And the people who put themselves on the front line. And again, MSF, there'll be a sort of glory, and I don't mean that in an unfair way, but a recognition of the midwives and the doctors and the healthcare professionals. And you think of the soldiers and the other workers who don't get that level of recognition. And I thought, again, going back to that concept of advantage, I think that I'm suffering. I think that I have it bad, and yet I have this interesting job with career prospects, with a good income, with satisfaction, with everything that goes with it. And I decided that that was where it ended, is that I was not going to spend the rest of my career feeling sorry for myself, that I was in a position to make choices. And back to that concept of empathy has to be at the heart of what we do, and recognising that we're not different, that every patient who's in front of you is your mother, your sister, your daughter, your wife, your husband, your father. They're not someone different. I had an experience the other day when I went into Royal North Shore Hospital, big tertiary hospital. I used to be known there, but I don't go there so often anymore, and I went in to see a patient of mine, and I stood at the desk, and the two nurses at the desk ignored me completely. They didn't know who I was and had no reason to. And I waited, trying to work out how to deal with this situation, because I thought if I make a move, then it could look as though it could look confrontational, and would that then create reputational risk for me, and all these thoughts going through my mind. And I waited until finally one sort of looked up, and I jumped in and I said, "I'm Vijay Roach, I'm a gynaecologist in the hospital. I have a patient who's here. Could you tell me where she is?" And fairly dismissively, she told me the bed where she was, and I made my way there, saw the patient, and then left. And I had this sort of odd thought in my head, and I thought, I wondered if I had been a patient in that hospital, and my father, I don't know why he came into my head, but I imagined my dad arriving and standing there and feeling worried because his son was sick, and anxious because he's in this hospital, and probably running late because he hadn't been able to get a park, and he's standing there and they're just ignoring him. And then eventually, knowing how my dad would handle it, he would have got irritated and he would have raised his voice and he would have said, "I'm just here to see my son, can you please tell me where he is?" And the nurses would have then been irritated in return, and the whole thing would have gone pear-shaped, and he would have come to see me and he would have been feeling upset, and then he would have worried about, if they can't even talk to me, are they actually looking after him down in the corridor? And I had this thought that we need to think about the implications of our behaviour, because then Dad would have left that hospital feeling really anxious about whether I was going to be okay or not and whether I was in the right place. And we might think that that's not relevant. We might think that that's not our job. But the sort of downstream implications of not behaving well can be enormous. So think about each of those people that you meet and actually just do it in everything that you do as someone who's your friend. There's that thing about road rage, which is where someone pulls you over and you jump out of the car and you're yelling them and all that, and then you say, oh, that's my boss. And so you wouldn't have done it. If you'd known it was your boss, you would have waved. And so therefore, treat everyone that way. Treat everyone. I know there's that, we're in a Catholic hospital, you know, do unto others as you would have done to yourself. That's actually probably the only good thing that came out of the Catholic Church. But I didn't say that, all right. Okay. But that principle can underlie everything that we do, and you get a huge return on it. So my day starts with, and you saw my cape, you see, because I think that I'm a superhero. You think I'm a weirdo, but I think that I'm a superhero because I know that when I get out of my car and there's the maintenance blokes who are in the car parks there, and because if you go into a private hospital car park, BMW, Porsche, Audi, Red Holden, and so the blokes come and say, great car, Doc, and then they start talking about the car and I have no idea because all I wanted was a Red Holden. And that makes a lot of noise and annoys a lot of people. But the thing is that you then have that conversation. You say g'day. And as you get in the lift, you say hello to the guys who are taking the garbage bins. And I know all of the catering staff, and we chat. And they come from all sorts of different places. And so it's just interesting talking to them. And then it's really interesting when you say, oh, so what time did your shift start? And they say it started at 6, but I had to leave home at 4 o'clock in order to get here. And it just gives you a whole different perspective. And I realise that if I look at someone and I smile, I improve their day. That's a superpower. What an incredible thing to have if you want to use it. And then I thought, when we are going to talk about us and them, and we are going to realise who are we, I'll start the ball rolling. So I have a perfectionist personality. I had some patients who are sitting there in front of me, and my secretary had put a sticker on my notes, and my notes are meticulous, you know, all beautifully written. And I saw that sticker, and that sticker's supposed to be over there. And so I'm chatting away to them, and I'm very slowly peeling off the sticker so that I can put it in the right place. And the paper tore. So, you know, I can feel my heart rate going up yet again, but I'm just trying to, you know, tidy the paper up, and I'm thinking I'm going to have to rewrite the entire file, and what am I going to do? And these two they burst out laughing. They said, what are you going to do? What are you going to do with that? Are you going to stick it there? And I said, what do you mean? I'm totally in control here. And they said, no, you're not. You're freaking out completely because the paper tore. And, and this is someone I'm about to operate on. So... But the thing is that they could see in me that perfectionist personality, that personality that worries all the time. I operate every Monday morning, and I have done so for the last 20 years. And every weekend, I worry about how Monday is going to go in terms of time, because that's the thing that I feel anxious about. I was early today. I rang. I made sure that I had a car park, otherwise I would have left earlier. I made sure that I was going to be on time because I didn't want to be late, because that was important to me. And that's part of that personality. I think, what if the operating list runs late? So when's the first patient booked? And is that going to fall behind? And how am I going to deal with that? And I'm an obstetrician. So you're always going to be late because someone's going to have a baby in the middle of it. And yet, for 20 years, every Monday morning, we got up in the morning, the sun came up and the sun went down, and we survived it. And yet I still can't get that out of my head. So I recognise that in myself. And I know that there's a good aspect to that as well, because it means that I'm a competent doctor, and I care about things, and I check my results, and I operate carefully, and I don't just say, oh, well, she'll be fine and I hope it'll all work out. So there is a benefit to that personality, but what I need to recognise is when potentially it can impair me. I suffer absolutely, and I know that I've made jokes about it, but I suffer absolutely from imposter syndrome. I realise now with the position that I'm in, you need your CV, and my CV was so hopelessly out of date that I actually employed someone to put it all together. And when she sent it through, I thought, oh, wow, that's me. And every day I think, you know, is someone going to work out that I'm not really a competent obstetrician, that somebody else could have done that operation better than I did, that complication wouldn't have occurred if someone else had done it, that someone would have given a better speech, or that someone, I don't know whether someone would have been a better dancer, because I was busting some really good moves the other day, although my niece didn't agree. But I worry. I think, and I don't, it's not in some totally false way, it's genuine. When we have a thing, so as president of the college now, there's a thing called the Council of the Presidents of the Medical Colleges, CPMC, and so we all gather, and there are 13 recognised colleges. And I'm walking into that thing thinking I'm the least important person in the room. And will I open my mouth and say something that just sounds completely stupid? And then, of course, everyone's sitting there feeling that way and talking about the way they're feeling, and there's a realisation that no, actually, the benchmark to set for yourself is that you're a competent human being. So I am a competent doctor. I am a competent surgeon. I am a diligent surgeon. Those are the qualities that I have which don't place me above anyone else. Don't say to anyone that you're the best. Don't put yourself ahead of someone, I'm the best surgeon, because that person doesn't exist. Competence is sufficient, and competence is all that people are looking for, and competence is really all that you can ever hope to achieve. You might have greater expertise in particular areas, but don't put that pressure on yourself. I realise that when I'm exhausted, my wife is totally unreasonable. No, I realise that when I'm exhausted, I don't manage. And I realise that I am irritable or unreasonable or unable to cope. And so that I need a certain amount of sleep and I need a certain amount of rest, and I acknowledge that. I realise that some twit put KFC between the hospital and home. And that's their fault. No, but that I know that I need to be fitter, that I need to eat better, that I need to read more, that I need to find other things. And I realise that I have a limited capacity. I want to be everything to everyone, but I can't be. I am just who I am, and I realise those limitations. So my journey with the college was an opportunity that presented itself in a very sad way. Am I going okay for time? Yeah. Because there was a chap who was in charge of all the training and accreditation in New South Wales, and he was killed in a light plane crash in Fiji. And I had literally qualified for 6 months and was put in charge of all the trainees in New South Wales, half of all the trainees of our college. And I did that for 9 years, a massive job. And then at the end of that, I then joined the council, then I joined the board. And once you've been on the board for 6 years, you either nominate to be president or you step away. And so I nominated to be president. I was elected and started my presidency in November last year, and it will go through for 3 years. And it's this extraordinary job of being exposed to things that I would never have been exposed to, high-level conversations with government, policy sort of things, and a lot of committee work, meetings, phone calls, emails, all those sorts of stuff, really being able to connect with a whole group of people. One of the things that I recognised was that there is not a good enough relationship between obstetricians and midwives in Australia, and I don't know what it's like all around the world. And so one of my first meetings was with the Australian College of Midwives. And I said, we just got to talk. And all we did was have a cup of coffee. We didn't try to solve the world's problems. We just started to build relationships. And I think that's the thing that I'm looking forward to most with the college. And the other message that I've tried